I audible? Okay, thank you. I could see the screen now.
Good evening, sir.
Hi, Pa. Hi, hi, hi. Shall we start? Ma?
Yes, sir.
Okay. What do you think about congenital adrenal hyperplasia? Is it easy to understand or is it difficult to understand? Is there any physiology behind it? And if you know the physiology, will it be easy for you to understand the pathology? Yes or no? In what way congenital adrenal hyperplasia you are going to see in your daily practice? Yes, you can interact with me if I am audible to you. So, Gayatri, Sapna, you can answer. More the interaction, I can proceed further. Okay, then. So, you tell me in what way congenital adrenal hyperplasia cases are presenting with? When will you suspect a case of congenital adrenal hyperplasia?
Ambiguous.
Very good. See, right now, very good, very good. Right now, we don't use the term ambiguous. We use the term atypical genitalia. So, please use the term atypical genitalia hereafter rather than using the word ambiguous genitalia. Right? Okay.
Yes, sir.
Right. So, whenever you see any child, invariably we will be interested in asking one particular question, whether it is a mulga or mulgi, whether it is a boy or a girl. But when you have some ambiguity, when you find it very difficult to say the sex of the baby, then comes you need to think about an underlying congenital adrenal hyperplasia, right? So when you don't find a proper genitalia, external genitalia, you will be confused and you need to start thinking in terms of a congenital adrenal hyperplasia. Here, what happens in case of boys and what happens in case of girls at the time of birth when there is when there is an underlying congenital adrenal hyperplasia? Can you tell me what happened in case of boys and what happened in case of girls? In whom it will be easy for you to diagnose and in whom it will be difficult to diagnose? Anyone?
Precocious puberty in male child.
See, the child is
Atypical
just born, my dear boy. The child is just born. How can you say precocious puberty in a child which is born? How can you? A child is just born, day one. How can you say precocious puberty in case of boy? So, what does it mean?
As in earlier achievements.
So what does it mean? It is difficult in case of a boy. You catch my point? It is difficult in a case of a boy. But it easy to diagnose in case of a girl. Why is it so? Because girls will have atypical genitalia, whereas boys will have a delayed manifestation in the form of shock on the second week or third week of birth. So invariably, a girl with atypical genitalia can easily be diagnosed, whereas boy with a normal genitalia with a mild increase in pigmentation of the scrotal rugosity will make you too difficult to diagnose. Invariably, majority of the boys will present in the second week of life with profound shock. Can you tell me why the shock is due to?
Because of reduced aldosterone.
Okay, what is the role of aldosterone? Let's go from the basic. What is the role of aldosterone?
Sodium and water reabsorption. Potassium.
Fantastic, dear.
Express excretion.
So the role of aldosterone is sodium absorption, along with that water absorption. What else? That's all. Role of aldosterone. That's all. Has aldosterone has got any
Excretion
other
of
role beyond this?
excretion of potassium and hydrogen.
Fantastic. Excretion of potassium and excretion of which one? Excretion of potassium along with excretion of hydrogen
Hydrogen ions.
ion. So whenever aldosterone is absent, what will happen? Sodium will be lost in urine, water will be lost in urine, leading to hyponatremia and hypotension, and hypotension. Whereas absence of aldosterone leads to retention of potassium, leading to hyperkalemia, and retention of hydrogen in turn leading to metabolic acidosis. So what will be a clue in case of a boy right now? A boy usually presents with a profound shock in the second week of life because of this absence of aldosterone. The child slowly losing its sodium water, leading to hyponatremia, hypotension, retention of potassium and hydrogen, leading to metabolic acidosis along with hyperkalemia. So the manifestation is boy is quite delayed, as a result of which they will present with shock, whereas in girls it will be very very easy because of the manifestation as an atypical genitalia. Okay, so before jumping into the topic of congenital adrenal hyperplasia, let me ask my children, how does an internal, because I don't want to directly go into the topic of congenital adrenal hyperplasia, rather I would be interested in asking you one particular question: how sex differentiation is being made in the fetus? Can anyone? How sex differentiation happens? Anyone? No idea, my dear boys and girls. You have read in your physiology. I am not talking about pediatrics. I can't get you, da.
Based on presence of SRY gene, whether present or absent.
Fantastic. Gayatri, fantastic. So when you have SRY chromosome, SRY part of the chromosome, what will happen when you have SRY? That is sex determining region of Y chromosome. Usually you will have an undifferentiated gonad. In the presence of SRY. When SRY is present, that undifferentiated gonad will become testis, and in the absence of SRY, the gonad remains as a ovary. That's very very simple. So the internal genitalia, the gonadal differentiation is mainly based on the presence or absence of SRY. This SRY is obviously present in Y chromosome, as a result of which then the fetus contains this Y chromosome, which in turn contains SRY. The gonad is differentiated into testis. In the absence of SRY, in females, the gonad will become an ovary. So this is called as gonadal sex. So the gonadal sex is determined by presence or absence of SRY, sex determining region of Y chromosome. Very good. Now tell me, so you have a gonadal sex right now. Then tell me, how does the internal genitalia is formed? Can anyone? How does internal genitalia is formed?
Mesonephric and paramesonephric ducts.
Very good. So in fetus, they have both Wolffian duct and then Mullerian duct. Wolffian duct, you all know, this Wolffian duct is going to become vas deferens, going to become seminal vesicle and epididymis. So what does it mean? What does it mean? Wolffian duct is responsible for male internal genitalia. Male internal genitalia. Whereas Mullerian duct is going to produce your, what are all the things? Your fallopian tube, your uterus. So the female internal genitalia is formed by Mullerian duct. So remember, in fetus you have both Wolffian duct and both Mullerian duct. So your fetus again has the ability to produce both internal, both male or female internal genitalia. Now you tell me, after gonadal differentiation, how does this Wolffian duct and Mullerian duct become a exclusive male internal genitalia or an exclusive female external internal genitalia? So what is the next step? Tell me what
Testis
is that?
secretes a anti-Mullerian hormone which acts on the Mullerian hormone, and
So
it will degenerate.
very good. So if the internal gonad is testis, which is formed as a result of SRY chromosome, what happens? This testis, as you told already, what are all the things that are present in the testis? You have Sertoli cells, which produces what? Sertoli cells, which produces what? Just now you told you, no?
AMH.
Very good. It produces Mullerian inhibiting substance, which in turn inhibits the growth of female internal genitalia, and the testosterone in turn helps in the production of male internal genitalia. Absence of this Mullerian inhibiting substance and testosterone makes this persistence of Mullerian duct leading to female internal genitalia, whereas absence of testosterone leading to regression of Wolffian duct in females. So this is how your internal genitalia is formed, right? So now you have a gonadal sex which is determined by SRY chromosome. Then you have an internal genitalia formation which is mainly due to Mullerian inhibiting substance and testosterone. Present leads to Wolffian duct progression to male internal genitalia. Absence leads to regression of Wolffian duct and leads to persistent of Mullerian duct and leading to female internal genitalia. Now comes the third part. So you have gonadal sex, you have internal genitalia. Then what is external genitalia? What is external genitalia? Yes, Nisha, Gayatri, what is external genitalia? How does this external genitalia is formed?
Dihydrotestosterone.
Very good, very good. See, your gonadal sex is under the effect of SRY. Your internal genitalia is under the effect of Mullerian inhibiting substance and testosterone, whereas your external genitalia is under the effect of dihydrotestosterone. Yes. So if this dihydrotestosterone is present, your labioscrotal swelling become scrotum, your urethral folds will become urethra, and your genital tubercle will become glans penis in case of boys. But in case of girls, absence of dihydrotestosterone leading to labioscrota forming labia majora, urethral fold forming labia minora, and genital tubercle forming clitoris. That's it. So the effect of external genitalia is mainly under dihydrotestosterone. That's all. So this is the common basic thing that we need to know. So as we repeat and as you all aware of that, so one is gonadal sex, another is internal genitalia, and the third one is external genitalia. So your sex is not only determined based on the external genitalia, it also based on presence or absence of ovary and testis, and it also depends on presence or absence of either Mullerian or Wolffian duct features. And as a small revision, gonadal sex leading to SRY, whereas internal genitalia is due to Mullerian emetic substance and testosterone, whereas external genitalia is under the effect of dihydrotestosterone. Absence of SRY leading to undifferentiated gonad becoming a ovary. Absence of Mullerian inhibiting substance and testosterone leading to persistent of Mullerian structures leading to fallopian tube and female internal genitalia, whereas absence of dihydrotestosterone leading to leading to conversion of those urogenital sinus structures, labioscratal folds, everything becoming a female external genitalia. So what does it mean? Female sex is the default process of sexual differentiation. I repeat, female sex is the default process of sexual differentiation. So this is with respect to the development of fetal gonad, fetal internal genitalia, and fetal external genitalia. So, with this background, let us go and look for this congenital adrenal hyperplasia. So, what is this, my dear boys and girls? So, what is the tabular column? What is the flow chart that you and me are seeing right now? So, what is this called as? What is this called as? Very simple. What is this called as? Anyone?
Formation of steroid hormones from
So this
cholesterol.
is called as adrenal steroid biosynthetic pathway. I repeat, this is called as adrenal steroid biosynthetic pathway, right? So you have three parts in your adrenal cortex. Zona glomerulosa is zona glomerulosa, zona fasciculata, and zona reticularis. In zona reticularis, mainly your testosterone is formed. In zona glomerulosa, mainly your aldosterone is formed, and your zona fasciculata, so mainly your cortisol is formed. Just now we have discussed the aldosterone is mainly responsible for the production of, okay, the aldosterone is mainly responsible for the absorption of sodium and water. Absence leads to hyponatremia and hypotension. Now, so this is adrenal steroidal biosynthetic pathway. There are so many enzymes involved in this pathway. So what are all the enzymes involved? You have 21 alpha hydroxylase, you have 11 beta hydroxylase, you have 17 alpha, you have 1720 lyase. There are so many enzymes taking part in this adrenal steroid biosynthetic pathway. Now my question is, let us take one enzyme deficiency as an example, and let us extrapolate what are all the things that can happen as a result of this absence of an enzyme. Can anyone tell me? So choose an enzyme. Let's go for, so we have zona glomerulosa, zona reticularis, and zona fasciculata. Let us presume that the most common enzyme deficiency that can occur in fetus is 21 alpha hydroxylase. Can anyone tell me what will happen if this 21 alpha hydroxylase enzyme is absent in your fetus? So, what are all the catastrophic effects that can occur in utero? Can anyone tell me? What are all the catastrophic effects that can happen because of the absence of 21 alpha hydroxylase? Yes, I could see only two names, Gayatri, Nishant, Nishinta. Yes, tell me. So let me explain you. So look at this pathway. This vertical pathway is concerned with aldosterone production. This vertical pathway is concerned with cortisol production. And this horizontal pathway is associated with testosterone production. Let us presume that this 21 alpha hydroxylase enzyme is absent in the developing fetus. So what will happen? Because of the absence of 21 alpha hydroxylase, your aldosterone is not formed. Point number one. So what will happen because of the absence of aldosterone in the fetus? Nothing is going to happen because the entire metabolism of sodium, water, electrolyte is everything handled by placenta. So absence of this aldosterone in the developing fetus is not going to produce any damage at all with respect to electrolytic balances in the fetus. But what will happen? Because of this absence of aldosterone, nothing is going to happen in the fetus with respect to metabolism because placenta is handling everything. And again, because of the absence of 21 alpha hydroxylase, your cortisol will be low. Whenever your cortisol will be low, you are prone to develop an hypoglycemia. Again, in the fetus, it is taken care by your placenta. So nothing is going to happen with respect to sugar or with respect to electrolytes. But what will happen? Because of the absence of this 21 alpha hydroxylase, there will be excess progesterone, the substrate. There will be excess 17 hydroxyprogesterone, again the substrate. 17 excess progesterone in case of zona glomerulosa and excess hydroxyprogesterone in case of zona fasciculata. All these excess progesterone and hydroxyprogesterone bypass this. There is a defect here, and this excess hydroxyprogesterone and progesterone, what will happen? They will be invariably converted to the production of dehydroepiandrostenedione, and this in turn will be converted into androstenedione, and this androstenedione will be converted into testosterone. So in 21 alpha hydroxylase deficiency, there will be deficient aldosterone which is not going to produce any damage in the developing fetus. There is low cortisol again which is not going to be produce any damage to the developing fetus. The answer is it is taken care by placenta. But these excess precursors are directly converted to the unaffected pathway because these pathways are interlinked. So this unaffected pathway, because 21 alpha hydroxylase is not taking part in the production of testosterone. So what will happen? All these unused progesterone and unused hydroxyprogesterone are diverted to the production of testosterone. So what effect this testosterone is going to make in the developing fetus? There is an effect because this testosterone, the developing fetus is a boy. Nothing is going to happen. A little bit of increased penis size, a little bit of increased hyperpigmentation of the scrotum. So nothing is going to happen, nothing is going to be visible externally. A mild increase in pigmentation of the scrotal rugosity may be a manifestation, but if it is a developing fetus, but if it is a developing fetus, is a girl, what will happen? This excess testosterone will act on the clitoris, will act on the labioscrotal swelling, will act on the labia majora, will act on the labia minora, will act on the clitoris, leading to clitoromegaly, leading to fusion of labia majora, leading to fusion of labia minora, as a result of which you will fail to understand. So what will happen? If they fuse, the fusion leads to a scrotum-like structure, and the enlargement of clitoris will make you to think in terms of Cori penis. And then you will have a confusion whether am I dealing with a small size penis or an enlarged clitoris, or you will have a feeling whether it is an underfused scrotum or overfused labia majora and minora. That is what we aptly called as atypical genitalia in females. Now, after childbirth, what will happen? Invariably, a boy will have increased pigmentation. A girl will have an ambiguous genitalia. These are all the effects of excess testosterone. But after birth, placenta has lost its control over the electrolytic balances, and now the body of the fetus should depend upon this fetal aldosterone secreted by the adrenal gland. But you know, in 21 alpha hydroxylase, this aldosterone cannot be formed, as a result of which the child slowly started losing sodium and water in urine, gradually leading to a shock, hypotension, hyperkalemia, metabolic acidosis at the second week of life. So, girls, it is very easy to identify because of the presence of ambiguous or atypical genitalia, but in boys, the presentation is short because many of us fails to recognize the mild increase in pigmentation of the scrotal rugae. So, what is the manifestation of 21 alpha hydroxylase? In 21 alpha hydroxylase enzyme deficiency, there will be excess androgen production. There will be low aldosterone. Excess androgen production leads to atypical genitalia in girls, as we discussed right now, whereas excess androgen in case of boys leading to slight increase in penile size and a slight increase in rugosity of the scrotum. Whereas blood pressure will be low, low, low. The answer is because you are deficient in your aldosterone. Right? So invariably, both boys and girls will have hypotension shock in the end of first week or in the beginning of the second week. So what will happen in case of girls? In girls, this excess testosterone acts on the clitoris and labioscrotal swelling, leading to fusion, leading to atypical genitalia in case of girls, atypical genitalia in case of girls, and precocious puberty in case of boys, because they will have excess testosterone production leading to increase in size of the penis. So you have precocious puberty in boys, atypical genitalia in case of girls. So whenever any child with ambiguous genitalia presents at birth, or whenever any boy presents with shock, invariably our diagnosis is congenital adrenal hyperplasia, the most common cause for adrenal failure right now. Okay, so how we diagnose? There are so many causes for so many causes for absence of aldosterone. There are so many causes for atypical genitalia, but how does I confirm whether it is due to congenital adrenal hyperplasia? The answer is very simple. So, in congenital adrenal hyperplasia, in 21 alpha hydroxylase deficiency, there will be excess hydroxyprogesterone. So any boy with hypotension, any girl with atypical genitalia at birth, you need to take one simple blood test called 17 hydroxyprogesterone levels. Normally it is less than 100 nanogram per ml, but in case of CH, the values will be more than 1000. It can touch even 10,000, which were 17 hydroxyprogesterone values will be in case of 10,000s, but in case if the values are very very low, in case the values are very very low, what will happen? You need to give an ACTH, stimulate the stimulate the neonatal adrenal gland. You give ACTH, and this ACTH will try to act on the fetal adrenal gland and converts all underutilized and converts all precursors such as 17 hydroxyprogesterone, because there is a blocked pathway in the form of 21 alpha hydroxylase enzyme deficiency. So the investigation of choice in a suspected congenital adrenal hyperplasia is 17 hydroxyprogesterone levels. In case of doubt, give ACTH, then measure the value. It will be very, 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 very high. Why this hyperpigmentation? Whenever you have an adrenal failure, invariably by negative feedback mechanism, the fetal pituitary will try to produce more and more ACTH. This ACTH, after converting into melanocyte stimulating hormone, leading to hyperpigmentation of the entire body, and it acts on the precursor, but it leads to these precursors that those 17 hydroxyprogesterone will be converted to the unaffected testosterone pathway, because as I told you, they are intermingled. Okay, so the manifestation of 21 alpha hydroxylase enzyme deficiency is in both boys and girls. Hypotension is the rule, shock is the rule, whereas in case of boys, precocious puberty, whereas in case of girls, atypical genitalia. So, what is the treatment of choice after birth? After birth, the child cortisol is absent. There is excess ACTH production. This excess ACTH converts more and more 17 hydroxyprogesterone into testosterone, leading to further virilization. So, to stop further virilization and to give steroids to the patient in the form of hydrocortisone, so the child should be immediately started on hydrocortisone 10 milligram per meter squared per day. The child should be started on it, hydrocortisone tablet. So when you give hydrocortisone to the child, the hypoglycemia can be resolved because of the gluconeogenetic effect of hydrocortisone. And since you have given cortisol, by negative feedback mechanism, the fetal pituitary will stop producing ACTH, leading to prevention of further conversion of this 17 hydroxyprogesterone to testosterone. That's it. So, giving hydrocortisone, you cut off the ACTH induced testosterone production. Second one is the child is in profound shock because the child doesn't have any aldosterone, leading to shock. So, the child should be given lifelong hydrocortisone and lifelong fludrocortisone. Lifelong hydrocortisone and lifelong fludrocortisone. That's it. So this is all about the most common manifestation of congenital adrenal hyperplasia. The most common enzyme deficiency is 21 alpha hydroxylase. I repeat, what are all the manifestation? Hyperpigmentation in boys, shock in boys, atypical genitalia in case of girls, electrolytes will reveal hyponatremia, hyperkalemia, metabolic acidosis. Investigation of choice is 17 hydroxyprogesterone levels. If it is normal, still you suspect, you give ACTH and then you measure after 1 hour, it will reach 10,000s. Treatment, lifelong hydrocortisone, lifelong fludrocortisone. Right? Now, another question they will ask you. What is that question? Another question. How to prevent? So now the mother comes to you with this following complaint. What is the following complaint? Sir, madam, already I have a child with a congenital adrenal hyperplasia, atypical genitalia. Now, for the next time, second time, I am conceived. I didn't have menses. It has to come on 20th of this month, but today, 30th, urine HCG turned out to be positive. This child is also at risk for congenital adrenal hyperplasia. What will be the management of this antenatal mother? Now tell me. What will be the management of choice in the mother? Tell me.
Lodged.
So how does this steroids will help? How does this steroids will help? You give, what is the steroid you give? What is the steroid of choice and when has to be started? Tell me.
Dexamethasone.
Very good. Why dexamethasone? Because it has got the brilliant effect of crossing the placental barrier. Okay. So when you give maternal dexamethasone, it will reach the fetus, and this dexamethasone will be sensitized by the fetal pituitary gland. So it stops producing ACTH, as a result of which you can stop virilization in a girl child. Isn't it? Yes. So now, when will you start? By what age you need to start this antenatal dexamethasone? By what age? Can anyone tell me?
Mr.
You need to give antenatal dexamethasone by what age? In which months of amenorrhea? This is another
Third trimester.
important question.
Third trimester.
No, it will be very, 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 very late, my dear boy. It will be very, very late. But I appreciate your sincere attempt, because when you give antenatal dexamethasone in the third trimester, by the time if it is a female child, it would have been virilized, my dear boy. It would have been virilized. You can't do anything, because the full external genitalia formed by 10th week of life, intrauterine life. So what will be the answer? When you have a previous child with ambiguous genitalia and you have a suspicious congenital adrenal hyperplasia as a cause, then what you need to do, my dear child, as soon as the mother is conceived, antenatal steroid should be started. The mother says, by 20th my menses has to come, by this is 24th, I doubt whether I am pregnant or not. Even before testing HCG, you start your antenatal dexamethasone. Earlier you start, lesser will be the virilization of the female external genitalia. Later you start, more the manifestation of the virilization of the external genitalia of females. You can prevent shock after birth, you can prevent hyperpigmentation. The late you start, the more the virilization. So what is the answer, my dear boy, when it should be started? Yes,
As soon as possible.
as soon as the mother is conceived. Okay, second point. Third point, how long you need to conceive? So the mother says, by about fourth week or fifth week, the mother says, I am pregnant. My HCG is positive. Start dexamethasone. By about 10th week or 12th week. By about 10th week, you can do a chorionic villus sampling and look whether the enzyme is deficient or not. Whether whether it is a boy or a girl. If it is a girl, you need to continue that antenatal dexamethasone till delivery occurs, because once you start, the ACATH will be low. The conversion of 17-hydroxyprogesterone to testosterone will be low, so that you can prevent virilization of female external genitalia till birth. Till birth, by suppressing, by using negative feedback mechanism, by giving antenatal dexamethasone. But if it is a boy and you are detecting at 10th week of life, then you can stop dexamethasone, because the electrolytic abnormalities will be taken care by placenta. A little bit of virilization is not going to produce any damage to a male. In fact, they will be happy. As for joking. So what does it mean? I repeat, whenever you have a case of previous history of congenital adrenal hyperplasia, start dexamethasone as early as possible and continue till 10th week. By about 10th week, if it is a boy, stop, observe, start hydrocortisone or fludrocortisone after birth. If it is a girl, start steroids as soon as birth. And if you found to be girl, by about 10th week by chorionic villus sampling, continue till delivery. And continue hydrocortisone and fludrocortisone after delivery. That's it. After delivery. So this is the antenatal management of choice in case of congenital adrenal hyperplasia due to 21 alpha hydroxylase enzyme deficiency. That's it. So whenever you read any topic, only 5 points are more than enough. In 21 alpha hydroxylase, both boys and girls will have hypotension and shock. Boys will have precocious puberty, girls will have atypical genitalia. Both of them should receive lifelong hydrocortisone and fludrocortisone tablets. Antenatal management is by giving dexamethasone as early as the child is conceived, mother is conceived, and continue till 10th week. Boy stop, girl continue till delivery. In suspicious atypical genitalia, always you need to go for 17 hydroxyprogesterone levels. If it is high, the diagnosis is confirmed. If it is low, give ACTH. Look for increase in level of ACTH. You will increase in level of 17 hydroxyprogesterone to confirm your diagnosis. Biochemical abnormality that favors congenital adrenal hyperplasia as a cause for hypotension is hyperkalemic metabolic acidosis with hyponatremia and shock. That's it. Over. 21 alpha hydroxylase is over. Now, you tell me what will happen to. So, are you clear, my dear boys and girls? Is it okay for my kids to understand? Yes, sir.
Yes, sir.
Yes.
Getting
Yes, sir, clear.
Very good, my dear. Right now, this is classic form. What is this? This is classic form. This is classic form. I have two more forms. What is this? One is simple virilizing form. Another is non-classic form. It means the god is pretty enough to look that mother, and it may be due to giving less form of punishment. I'm not supposed to say, just for to make you understand. So in some instances, what will happen means, in some 21 alpha hydroxylase deficiency, they will have enough aldosterone. So what is simple virilizing form? They will have, okay, they will have simple, they will have enough aldosterone production. So what will happen? Enough aldosterone production means blood pressure will be maintained. So there will not be any shock at all. But what will happen? Again, this excess progesterone, hydroxyprogesterone, leading to testosterone synthesis and leading to what is that? Precocious puberty in boys and atypical genitalia in girls. So in 21 alpha hydroxylase simple virilizing form, your aldosterone synthesis is spared, leading to high androgen only. As a result of which, boy will develop precocious puberty and girls will develop ambiguous genitalia. But here, your aldosterone is normal, so no shock. So what will be the investigation of choice? Same 17 hydroxyprogesterone levels. But treatment wise, is there any difference in this treatment after a child? But what is the treatment? In classic form, you give lifelong 21 lifelong hydrocortisone and fludrocortisone. Here, aldosterone synthesis is spared. So, is there any need to give fludrocortisone tablet here? Can anyone tell me yes or no? No need. So, in simple virilizing form, to cut the ACTH production, converting your unused hydroxyprogesterone to testosterone, you just give hydrocortisone alone to prevent the ongoing virilization. There is no need for fludrocortisone in simple virilizing form. Is it possible for you to understand right now, my dear boys and girls? Yes or no? Okay. So here aldosterone is fat. So no need to give fludrocortisone, which is a synthetic mineralocorticoid. Right. The third one is, what is this? Non-classic form. Can anyone tell me what is non-classic form? Here there will be only partial deficiency of 21 alpha hydroxyl. Very, what is that? Partial deficiency of 21 alpha hydroxylase. So what will happen in this non-classic form? Can anyone tell me? Can anyone tell me partial deficiency? Here they can produce aldosterone. They can produce aldosterone. So there will not be any shock. So BP will be normal. Okay, and also they will be able to produce only minimal increase in androgen. So that what will happen in case of girls, They will not bond with virilization. I repeat, they will not bond with virilization. Yeah, but a little bit of increase in testosterone levels, androgen in case of girls, leading to hirsutism in girls, boyish voice in girls. Voice change. That's all. Only manifestation is not shock, is not complete virilization of external genitalia, only hirsutism and voice change, boyish voice in case of girls, nothing to do with in case of boys because already they have good androgen. That's all. So, what are all the three forms of congenital adrenal hyperplasia, my dear boys and girls, with respect to 21 alpha hydroxylase? The answer is very simple. Now I have first manifestation is BP. Next manifestation is precocious puberty. Third manifestation is atypical genitalia. In 21 alpha hydroxylase classic form, BP will be low, precocious puberty in case of boys, atypical genitalia in case of girls, and the treatment is lifelong hydrocortisone and fludrocortisone. Whereas in case of what is that simple virilizing variety, aldosterone synthesis is retained. So BP will be normal. But because of this deficiency, again excess precursors will be converted into what is that? Excess precursor will be converted into androgens, leading to again precocious puberty in boys, ambiguous genitalia in case of girls. But here the treatment is only hydrocortisone, no need for fludrocortisone. The third variety, they retain aldosterone as well as they retain some effects of 21 alpha hydroxylase. So in non-classic form, BP will be normal, voice will be normal, but a little bit of hirsutism in girls and a little bit of boyish voice in girls, voice change in girls. Rest you need to give only hydrocortisone. These are all the three manifestations of 21 alpha hydroxylase, the most common cause of adrenal failure in children, most common cause for adrenal failure in newborn. Right? Am I clear, my dear boys and girls?
Sir, won't we have hirsutism in classical form of 21 and alpha hydroxylase deficiency or the simple form?
Very simple, my dear boy. They will have hirsutism, voice change, virilization, everything will be there because complete absence leading to complete conversion of these unused hydroxyprogesterone, and almost all of them will be converted into testosterone. Whereas in case of non-classic form, there will be only partial loss of 21 alpha hydroxylase. The amount of testosterone, yeah, surge will be less compared to classic form. So this little bit of testosterone unable to produce virilization of the external genitalia, but enough to produce this simple manifestation of hirsutism and voice change. Because the amount of testosterone that is produced in non-classic form is very, very less to cause virilization of external genitalia. Okay, my dear boy. Then comes the rest of the things are very, very easy. In 11 beta hydroxylase, what happens? 11 beta hydroxylase is here. 11 beta hydroxylase is here. So, what will happen in 11 beta hydroxylase deficiency? Again, look here, there will be same excess progesterone. All of them will be converted into excess 17 hydroxyprogesterone. These unused precursor will go and act on the, they will be converted into androstenedione, which in turn will be converted into testosterone. So what happens in 11 beta hydroxylase deficiency? The same. Precocious puberty in a boy, atypical genitalia in a girl. But what will happen? Because there is excess androgen, the answer is yes. But remember, what happens in 11 beta hydroxylase deficiency? In 11 beta hydroxylase deficiency, you will have 11-deoxycortisone. What? 11-deoxycortisone and deoxycortisol. Remember, in 21-alpha hydroxylase, the basic precursor progesterone is produced, which doesn't have any mineralocorticoid activity. But in 11-beta hydroxylase deficiency, the precursor produced is 11-deoxycorticosterone, which has got mineralocorticoid activity, as a result of which you have excess mineralocorticoid. You have excess mineralocorticoid because this unused 11-deoxycortisone, which has got mineralocorticoid activity, acts on collecting duct to absorb more and more sodium, to absorb more and more water, leading to what? Hypertension. Leading to what? Hypertension. So, what is the hypertension? So, what is the difference between 21 alpha hydroxylase and 11 beta hydroxylase? The answer is very, very simple. So, BP, boys, girls. In 21 alpha classic form, BP will be low, precocious puberty in boys, ambiguous or atypical genitalia in girls. In 11 beta hydroxylase, the same precocious puberty in boys, the same atypical genitalia in girls, but because of excess 11-deoxycorticosterone, which has got a beautiful mineralocorticoid activity, they act like an aldosterone. Because of this block, there is more and more and more deoxycorticosterone formation, which acts like a aldosterone and absorb more and more water and more sodium, leading to hypertension. You catch my point? The only difference between 21 alpha hydroxylase and 11 beta hydroxylase is presence or absence of hypo or hypertension. The precocious puberty in boys one and the same. The ambiguous or atypical genitalia in girls is one and the same. Whereas hypotension in case of boys leading to because of this precursor just progesterone, which doesn't have any mineralocorticoid activity. Whereas in 11 beta hydroxylase deficiency, there is excess more and more 11 deoxycorticosterone, which can act like a aldosterone, leading to hypotension. The treatment, and as I told you already, hydrocortisone and fludrocortisone in case of classic form, whereas hydrocortisone is enough in 11 beta hydroxylase because you already have excess 11-deoxycorticosterone, which is a mineralocorticoid. The purpose of giving hydrocortisone is to prevent further conversion of these unused products into testosterone. Am I correct? Is it easy right now to understand the 11-beta hydroxylase rather than simply mugging up? Just have a three-dimensional view of this aldosterone, adrenal biosynthetic pathway. Rest of the things you can apply your knowledge rather than mugging up. Is it correct? Yes or no? Is it okay for you, my dear boys and girls? Okay, baby?
Yes, sir.
Very good. Now I have one pathway in which 21 alpha hydroxylase and 11 beta hydroxylases are affected. Now this pathway is over. The vertical pathway with respect to aldosterone, the vertical pathway with respect to cortisol is over. Now let's go to the horizontal pathway, which is useful in the production of testosterone. Now let's go to our graph again. The adrenal steroid biosynthetic pathway again. Look here. Now this pathway is not affected. 21 alpha hydroxylase is not affected. 11 beta hydroxylase is not affected. What will happen when this 17 alpha hydroxylase is affected or 1720 lyase is affected? Now you tell me, apply. When this 17 alpha is affected, when this 1720 lyase is affected, what will happen? They play a role in the production of what? Androstenedione. This androstenedione will be useful for the conversion of testosterone. Now, if this 17 alpha is absent, if this 1720 lyase is absent, what will be the damage? Testosterone will not be produced inside the fetus. So who will be having an issue at present? Tell me. Is it a developing female fetus or male fetus? Absence of testosterone. As I told you already,
Male.
female sex is the default process of sexual differentiation. So absence of testosterone leading to absence of fusion of labioscrotal swelling, absence of fusion of urethral fold, absence of fusion of genital tubercle converting into penis, leading to atypical genitalia in
Males.
boys. Females will be normal because, as I told you already, female sex is the default process of sexual differentiation. So right now there is no role of precocious puberty right now, but I have here atypical genitalia in boy right now, in which 17 alpha hydroxylase and 1720 lyase. Okay, baby, 17 alpha hydroxylase and 1720 lyase. Now the excess precursors, because of the absence of 17 hydroxyl progesterone and 1720 lyase, the excess pregnenolone, the excess progesterone, the excess hydrocortisone, the excess cortisone will be converted into aldosterone. This vertical pathway is quite unaffected, leading to dash. Leading to dash.
Hypertension.
That's it, leading to hypertension. Here androgen is low. That's all over. Again here also 17 OHP is high. Again you just need a hydrocortisone to suppress ACTH conversion of these unused products into aldosterone. Now apply the simple graphics. In case of 17 alpha hydroxylase, the horizontal pathway, 1720 lyase, the horizontal pathway, testosterone is not formed. So what will happen to BP? What will happen to boys? What will happen to girls? BP will be very high in both boys and girls because of aldosterone unaffected. Boys will have atypical genitalia. Girls' genitalia will be normal. TK baby, very simple. That's it. Is it okay?
Right, sir.
Okay. Is it
Yes, sir.
so? Is it difficult to understand right now? No. Now let me go to the next pathway. Let me go to the next one. So you know 17 alpha hydroxylase is gone, 1720 lyase is gone. Now let us concentrate on one more subtle enzyme deficiency, 3 beta HSD. 3 beta HSD helps in the formation of aldosterone. Yes or no? Tell me yes or no. Come on, boys.
Yes.
Yes. So aldosterone will be low. So the developing fetus will have hypotension after birth. Yes, no. See, in 3 beta HSD, aldosterone is formation is not occurring. So the child will have hypotension at birth. Yes, no. Understood or not?
Yes.
Yes.
Yes, sir.
Yes. Okay. One point. So the child will have hypotension. So the child will have hypotension. Again, this 3 beta HSD is also taking part in the formation of cortisol. So low cortisol leading to negative feedback mechanism, leading to high ACTH, leading to the conversion of precursors. Now let us see here. This 3 beta HST also converts the weak androgen dehydroepiandrostenedione to androstenedione, which in turn is converted into testosterone. Now, what is the excess precursor in case of both boys and girls? Can anyone tell me? What is the excess precursor right now? Previously, either testosterone present or absent, but here it is neither testosterone, it is the dehydroepiandrostenedione. Now tell me, in both boys and girls, this dehydroepiandrostenedione is high. Yes, no? Yes or no?
Yes.
Yes. So what is the role of this dehydroepiandrostenedione? Tell me.
Auxiliary to
Is it a weak androgen, or is it a weak androgen or a powerful androgen?
weak androgen.
Weak androgen. So what is the role of a weak androgen? So if it is a boy, what will happen? This weak androgen cannot cause complete fusion of labia majora, cannot cause complete fusion of labia minora, cannot cause urethral growth or clitoral growth, leading to what happens? Hypospadiasis in boys. What? The man is so weak androgen. Dehydroepiandrostenedione is a weak androgen. If it is a testosterone, it will pull the urethra up to the tip of the penis. But here, the weak androgen doesn't have the power of pulling the urethral goal up to the tip of the glands, leading to hypospadiasis in boys. So what will happen in boys? Boys will have hypospadiasis. So there is undervirilization in boys. What will happen in girls? Tell me, dear, what will happen in girls? This excess dehydroepiandrostenedione is an androgen which is unnecessary for a female. So this excess dehydroepiandrostenedione androgen leading to little bit of masculinization. That means in females they will have clitoromegaly, they will have hirsutism. You catch my point? You catch my point, my dear boys and girls?
Yes, sir.
Yes. So the excess dias which is unnecessary for a girl leading to hirsutism. This excess dia which is not as equivalent as a testosterone leading to underutilization in a boy. So what is the manifestation right now? You tell me. Very simple. So in 3 beta HST deficiency, what will happen? Dias will be very high. So in boys, hypospadiasis. In girls, hirsutism as well as clitoromegaly. And remember, this beta HST is helpful for the production of aldosterone. So what will happen to BP? BP will be very low. So hypotension with hypospadiasis with hirsutism. Please remember the triple H in case of dias. Hypotension in both, hypospadiasis in boys and hirsutism in girls. Is it clear right now? Is it clear? Yes. Now what is the investigation of choice? Here comes the trick. For any congenital adrenal hyperplasia, you must be wondering that in either in 11-21 alpha hydroxylase or 11 beta hydroxylase or 17 alpha hydroxylase or 17-20 lyase, the excess precursor is 17 hydroxyprogesterone. Yes or no? Yes. So that is a screening test. But what happens in 3 beta HST? The pregnenolone is converted into progesterone. The 17-hydroxypregnenolone is converted into hydroxyprogesterone only with the help of 3 beta HST. So, what happens in 3 beta HST? If you rely on 17-hydroxyprogesterone, you will be in a wrong node. So, what happens? Here, the 17-hydroxyprogesterone will be low, unlike in other enzyme deficiencies. So this is the clue. When you have a hypospadiatic boy, when you have a hirsutic or clitoromegaly in a girl, when you have a hypotension in a both boys and girls, and instead of looking at 17 hydroxyprogesterone which is common in all conditions but not in 3 beta HST, what will happen? The answer is simple, my dear boys and girls. It is high pregnenolone to progesterone ratio, or 17 hydroxyprogesterone to 17 hydroxypregnenolone ratio. Very simple. The pregnenolone is high, the 17 hydroxypregnenolone is high. It is not 17 hydroxyprogesterone. That's why this star mark. You catch my point, my dear girl, boys and girls? So 3 beta HST, hypotension in both boys and girls, hirsutism in boy, hypospadias, hirsutism in girls, hypospadias in boy. It is not 17 hydroxyprogesterone. It will be low, 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 low. It is high pregnenolone, high 17 hydroxypregnenolone. Treatment: I don't have BP right now, my dear boys. So I need to give what? Fludrocortisone. I don't have this hydrocortisone. So I need to provide lifelong hydro. So like classic form of 21 alpha hydroxylase, you need to provide lifelong fludrocortisone and hydrocortisone. Is it easy or tough? Is it easy or tough, my dear boys and girls? 3 beta HST. Okay. And finally, star protein deficiency. So what is the role of star? Star is in the first enzyme in the pathway. So in steroid activate, so what is this? Whenever there is a deficiency of star protein, your aldosterone is not formed, so you will have invariably have low BP. Your cortisol will not be formed, so you will have hypoglycemia. Because of, and when you think in terms of excess testosterone, it is not so, because star is the initial enzyme, so there will be absence of testosterone in star, so there will be low androgen in star protein deficiency. So because of, there will be low BP, low androgens, so what will happen? Boys will have a atypical genitalia, girls will be normal. Boys will have atypical gender because testosterone itself is not formed. Okay, majority of this will die at birth because of no pregnenolone, no progesterone, nothing. They will die at birth. Okay, if they survive, you need to give both hydrocortisone and fludrocortisone. So this is all about congenital adrenal hyperplasia. If at all someone wants a revision within a minute, so let me start. So in 21 alpha hydroxylase deficiency, BP will be low, precocious puberty in boys, atypical genitalia in girls. I will provide both hydrocortisone and fludrocortisone. The investigation of choice is 17 hydroxyprogesterone levels. In simple virilizing form of 21 alpha hydroxylase, BP will be normal, but boys will have precocious puberty, girls will have atypical genitalia. Only fludrocortisone is not necessary, but you can give hydrocortisone. Investigation of choice is 17 OHP. What is non-classic 21 alpha hydroxylase? BP will be normal. Boys will have little bit of precocious puberty. Girls will have only hirsutism, like 3 beta HST, but not frank virilization. Treatment of choice only hydrocortisone, and then investigation of choice 17 OHP, and then 11 beta hydroxylase deficiency. BP will be very, very high because of deoxycorticosterone, that is high. Boys again will have precocious puberty. Girls will have atypical genitalia. Girls. And remember, here alone hydrocortisone is sufficient. Investigation of 17 OHP. In 17 alpha hydroxylase and 1720 lyase, excess precursors leading to aldosterone production. So BP will be high. Boys will have atypical genitalia. Girls will have normal genitalia. And remember here again, the only you need to give hydrocortisone, no need for fludrocortisone, and here again 17 hydroxyprogesterone level. Whereas in 3 beta HST deficiency, BP will be low because aldosterone is affected. Boys will have hypospadiasis because it is not the testosterone, it is dias, which is a weak androgen. Girls will have hirsutism and clitoromegaly. Okay, what will happen to a treatment? You need to give lifelong hydrocortisone. You need to give lifelong fludrocortisone. Investigation of choice is here 17 hydroxypregnenolone and not progesterone. 17 hydroxypregnenolone by 17 hydroxyprogesterone values will be very high. Okay, so this is all about congenital. So what are all the manifestations of congenital adrenal hyperplasia? What are all the manifestations of congenital adrenal hyperplasia? Again, to complete my session, any boy with shock in the second week of birth, a boy with shock with a negative sepsis screening, a boy with the early onset puberty or virilization, a girl with ambiguous genitalia, a boy or girl with the early onset hypertension in case of 11 beta hydroxylase and 17 alpha hydroxylase, boy or girl with increased pigmentation in almost all forms of enzyme deficiency. So 21 alpha hydroxylase and 3 beta HST star protein deficiency. In these three things, BP will be low. Whereas in 11 beta hydroxylase, 17 alpha hydroxylase, 1720 lyase, BP will be high. So that's all about today's session. Thank you for your patient listening. If at all you have any doubt, proceed. Over.
Could we get questions from the rarest of the rare types of
No, let me tell you. So as far as my students are concerned, what are all the questions they will ask you? Question number one. Question number one. A 2-year-old, a 7-day-old child brought with shock. Sodium 120, potassium 7. Okay, HCO3 3. Okay, so hyponatremia, metabolic acidosis. So what is the investigation of choice? Investigation of choice is 17 hydroxyprogesterone. This is first question. Second question, how to prevent antenatal? Second MCQ, antenatal dexamethasone. Dexamethasone they have asked almost 5 times in a NICT. What drug? You have many drugs, but dexamethasone is the drug of choice. When? Question, as soon as. Boy, cut by 10th week. Girl, continue. These are all potential MC. Second set. Third set. Hypotension, hypertension. Hypotension, as I told you, only 2 enzymes. Hypotension means what? 21 alpha hydroxylase, 3 beta HST. Hypertension, high BP. Hypertension, high BP, 2. 17 alpha hydroxylase, 1720 lyase, 3 beta HST. That's all. This alone is more than enough. This alone is more than enough for you. The last one we covered now, that is more than enough instead of going deep. See, you apply the graph, you apply the enzyme deficiency. Why? What is the need to mug up? Just 3 to 4 times you see this aldosterone biosynthetic pathway. There is no need to mug up. Why you are asking rare, common? No, that's it. Very easy. Still, you won't ask any doubt. I am here to clear it. Shall we wind up? Almost it is 1 hour and 15 minutes.
Sir, do we give antenatal steroids in all cases of CH?
Whenever, yes, you need to give you need to give antenatal dexamethasone because see what happens in case of 17 alpha, you don't know till birth. See, when you have a proper diagnosis in the previous childbirth, then it is okay. Okay, But when you don't, only the history is atypical genitalia, means how do you know that it is due to 17 alpha, 11 beta? You don't have any answer. So if it is 17 alpha, if it is due to 17 alpha hydroxylase or 1720 lyase, what will happen in case of 17 alpha? In rest of the things, it is okay. In 21 alpha hydroxylase, in 11 beta hydroxylase, in 3 beta HST, okay, you are going to prevent the virilization. Okay, so mandatory. In the remote possible of 21 alpha hydroxylase, okay, you do the default process testosterone will not be there, but the testosterone is essential up to 10th week. So how do you know that which enzyme? So in almost all cases of congenital adrenal hyperplasia, you need to start antenatal dexamethasone.
Thank you, sir.
Okay, right.
Yes, sir.
So shall we wind up, dear?
Thank you, sir.
Okay, okay. Bye, 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 bye. We will soon meet in some other session. That is your choice. That is your choice. Okay. Bye bye. See you. Good night.
Sir.
Bye, ma.
Thank you, sir.
Bye, Raja.